You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome to the Pre-Hospital Care podcast with myself and Walker. In this session, we're looking at combat casualty care with Ed Barnard. So what I wanted to do is just examine the bleeding patient in the tactical and combat environment. I wanted to dig into some of the fundamental education that's challenged practice in recent years. And I also wanted to look at the sequential approach to bleeding and some of the second and third generation haemostatics, the pharmacological agents, tourniquets, a little bit around neck wounds and injuries, blunt and junctional wounds, and then also hypotensive management as well. So what we wanted to do is examine the utility and the success of some of these highly interventional skills at near or point of wounding, and also look at traumatic cardiac arrest and the utility or not of an algorithmic approach to management. So as I said before, I've got Ed Barnard with me. Ed is an EM consultant within the Cambridge University Hospital group. He's also undergone subspecialty training in pre-hospital emergency medicine, working in more than 5 different EMS systems. He's also an educator and mentor and has students and doctors in training and gives national and international lectures. He also is completing a PhD, has published over 30 articles within journals and received some international awards along the way. He's also, if that wasn't enough, a senior lecturer for the military. Welcome to the podcast, Ed.
Thanks, Ian. It's a pleasure to be here.
Ed, if we could just start with getting your perspective on the sequential approach to external hemorrhage control, and maybe just some of your anecdotal experience of whether it's worked for you and or clinicians around you.
Yeah, sure. So I think what you're getting at is this approach of first applying direct pressure to a wound and elevating the wounds, and then thinking maybe about trying to control that bleeding from a pressure point where you can get to the vessel above. And then on to things like arterial limb tourniquets. I think probably the patients that I tend to see either militarily or in pre-hospital civilian practice, we're really conscious that every drop of blood is precious to these patients, and those patients tend to be those who have lost a decent amount of blood, might have other injuries in the chest or the head as well. So in those patients, I think typically, even if working in a small team, we'd want to control hemorrhage really quickly and not lose any more blood than is absolutely necessary. So although the sequential approach or that ladder approach to bleeding is important overall, particularly if you're dealing with someone who's nicked their finger when they're cutting up some food in their kitchen, I think most of the patients we go to, we often see or often do place a tourniquet to get immediate control, look at other aspects of the patient in terms of airway breathing, and then come back to that later to then, in lots of cases, remove that tourniquet, apply direct pressure, maybe use a novel hemostatic dressing with that. So I think it's a really important paradigm and one that we'll continue to teach and talk about. I think in reality, in severely injured trauma patients, we know that even a small amount of extra blood loss is really important. And there'll be other things that we need to do in a small team with only a few pairs of hands that we're going to use a tourniquet probably more readily than you might think from looking at that escalation of bleeding control.
So looking at second and third generation hemostatic dressings, some of the learning I got around sort of using these dressings was really getting it to point of bleed. And, there's no point in having a fancy dressing or indeed an expensive dressing acting as a sponge and indeed not really providing any hemorrhage control or indeed providing the pseudo clot which is needed at point of bleeding. Could you maybe speak to some of your salient points or salient learning points around these dressings as you've used them?
Yeah, sure. So I think a few important points up front. The most important one probably is that they're used with direct pressure, not instead of it. Right. So you're using this hemostatic dressing, whichever one you choose. And I can't remember what's first, second, third, or even fourth generation, I think is now described. So yeah, it's direct pressure with the hemostatic dressing. Each product's different, of course, so you need to read the instructions for the dressing that you carry on service and need to do that before you have to use it on a patient. And then you raised the point as well that it should be applied to the source of bleeding, not around it. Now, the history of hemostatic dressings is pretty interesting. I won't go into it in depth, but basically there were some developments, I think in a slightly amateurish way after calls from the US government to rapidly innovate novel hemostatic agents, essentially. And some of those first agents used something called zeolite, which I think is volcanic ash, and that caused an exothermic reaction with water against it. And by that, what I mean is it got very hot. So that caused some concerns about burns around the wound. There were some reports of rescuers getting it in their eyes, which of course are wet on the front, so they get, potentially corneal burns as well. All of that's gone away, and what we essentially now have are either mucoadhesive agents or procoagulant supplements. There are two products, so there's a wealth of literature looking at these and comparing them to either each other or to gauze. And there's limited evidence, really. No good evidence between different versions of hemostatic dressings, and I would say limited evidence as to whether they're better than well-placed gauze. So just to cover that off quickly, so quick clot combat gauze and Celox, I think are both third generation, might be fourth generation, but those are the two that you'll probably be exposed to. The US military, I think, moved from quick clot combat gauze to Celox as well in the recent past. And Celox is manufactured, I think, in the UK, and that has been the hemostatic dressing of choice in UK defence for recent years. And that's a bit flaky, can be difficult to pack into a really tight space. And that leads me on to the bit I just said earlier about, although there is evidence from the animal lab and some limited human data demonstrating beneficial effects of hemostatic dressings against simple gauze, one thing that is different is the ability to tightly pack and quickly tightly pack these into a wound. And if you've handled gauze, even if it's the little 5-pack for that you'd use when you're putting a cannula in, it's really pliable, really soft. So that can be pushed in really effectively against something that's bleeding with direct pressure attached. So I think they're here to stay. They've definitely got some popularity. And I think the things to remember are, know the kit that you're using, so read the instructions before you need to use them, and remember that you need to apply direct pressure through that dressing. It's not a substitute for applying pressure.
So shifting tone slightly and/or focus, and just looking at sort of self-application tourniquets, Ed, for a minute. Have you sort of seen the decreased trend in usage of tourniquets sort of due to successful other means of hemorrhage control? And I guess I'm asking this question because, within my practice over 20 years, I probably have only put a handful of tourniquets on because of successful primitive methods, so to speak. But what's your perspective?
I think I'm actually seeing and have seen an increase in the use of tourniquets. Now, part of that clearly is about availability. So I don't know about where you work. I mean, obviously, militarily, everyone's got tourniquets on them and they're all over the place, right? For obvious reasons, which I think we'll discuss in a minute. In civilian ambulance services, they're also really widespread now. So every EMS vehicle in my region has a blast, bag. So I think once you've got the tools, you're going to start using them. So I don't infrequently see them on nasty pretibial lacerations, for example, to try and control hemorrhage. So I think there's probably more of an issue around inappropriate use than there is around people not using them because they've got other means of hemorrhage control, i.e. novel hemostatics, which, as it happens, are in the same bag, I think, in most people's kit as the CA tourniquets. So, and that's not necessarily a bad thing if it's not causing very acute tissue damage. But in answer to your question, I'm absolutely not aware that I've seen a reduction in these tourniquets. But as you say, the frequency with which they're used in our civilian practice anyway is so low that it'd be difficult probably to pick up any signal in that.
So looking at sort of the concept of arterial spasm for a minute, Ed, and recoil, and sort of maybe some of the resultant iatrogenic sort of hemorrhage control that occurs from recoil. Could you maybe speak to sort of whether you've seen that yourself in practice?
Yeah, interesting. I guess we all think about the Black Hawk Down film, US forces in Mogadishu with this, don't we? And I can only think of a single patient. There's probably been a few, but I can think of a single patient delivered to us in a UK deployed facility who had been blown up, I think steps on an IED, non-UK, non-coalition forces, and had been transported in the back of a pickup truck and literally delivered to our facility. And I don't think we got exact timings, but it was something like 90 minutes, 2 hours from the time of injury to arriving at our emergency department. And this patient was obviously pale, collapsed veins, in severe hemorrhagic shock, but had quite high amputations through the thighs. No tourniquets applied, right? So this patient hadn't exsanguinated to death, but had held on. Of course, as soon as we started filling them up, then blood started pouring out of their legs, and I needed pneumatic tourniquets. So, in terms of is there still a role for tourniquets, the answer is absolutely, absolutely yes. And there's not very good data because no one would let us do a study now, clearly, of tourniquet or not tourniquet for a high bilateral amputation. However, I think the best data we've got is probably from the US that was published in J Trauma in 2006 by Joseph Kelly, which took 2 different time periods with about 500 patients in each. And that spanned the introduction, or the reintroduction, I should say, of arterial limb tourniquets to combat medicine. And what we see in these data is an 85% reduction in mortality associated with extremity injuries. And that's probably the best evidence that we're ever going to get. I think in terms of lessons that in my brain, when I talk to people about the use of tourniquets, particularly around blast injury, is in civilian practice for blunt amputation, we try and place that tourniquet as close to the injury as possible to preserve as much tissue. The problem in blast is that in some situations that muscle and other tissues are flayed away from the femur typically. So what you need to do in those casualties is to think about placing a tourniquet a bit higher, because if you place it right down by the wounds, there's a lot of destruction more proximal to that, which will continue bleeding. I think the other thing about blast really is that you would typically get quite nasty perineal and buttock injuries, which are like relatively easy to miss, I suppose. If you've got clothing on, don't roll the patient. So be highly suspicious of a patient, certainly with an above knee amputation from blast, that they had a perineal and or large buttock wounds which need packing. And the use of the pelvic binder in that situation has got two roles. And the first role is really, really useful at holding in packing and first field dressings and blast bandages into those wounds in the buttock. The second one is, we know from some not very good data that I did, that if you've got a single above ankle blast amputation, you have a 1 in 5 or 20% chance of a pelvic fracture. And if you've got bilateral above ankle amputations in the field, then you've got a 25% or 1 in 4 chance of a pelvic fracture. So those, it's also associated with abdominal solid organ injury. So those are a few of my sort of take homes, I guess, that lead from your question. I think the other thing to mention probably is bone bleeding. If you've been in a situation where you've had a fractured bone with an amputation, and it's very difficult to get that bone to stop bleeding, and there's no really good answer to that. Hopefully it's not too catastrophic, and you can use novel haemostatics and and diet pressure, but a tourniquet isn't going to stop that bleeding.
So Ed, just looking at neck wounds for a minute and just looking at sort of zonal borders, for those that might not be familiar around zone 1 to 3, could you maybe just speak to the zones of the neck and indeed which zones in your mind sort of carry the greatest mortality?
Yeah, sure. I think the first thing to say is it's taken me about 15 years to remember which is zone 3 and which is zone 1, but I'll more than happily go along. So zone 1 is, in my mind, clavicles to the inferior border of the cricoid cartilage in the neck. And then zone 2 includes all the cricoid up to the mandible, up to the angle of the mandible. And then zone 3 is from the angle of the mandible up into the base of the skull. I think probably also important to mention that penetrating neck injury has to go through the platysma, which is that thin muscle layer on the front of your neck. And also people talk about neck triangles. So I can remember being taught about this at medical school and never really knowing why it was important. But most of the vital structures in your neck, so large blood vessels, airway, esophagus, all lie within the anterior triangle, which is the anterior border of the sternocleidomastoid, or that muscle you can feel running across the side of your neck. So that's the anatomy. I think I'm not aware of any consensus guidelines for the management of penetrating neck injury in the pre-hospital setting, as it's all kind of ED based, which you can translate a bit, but of course, we haven't got CT. I think the first thing I would say about that, though, of course, is that what you see on the outside might not necessarily be what's on the inside. So although you might see a penetrating wound in zone 2, there could be structures in zone 1 or zone 3 that are affected. Zone 2 is the most common site of injury, which you might expect. I think it's the largest in terms of actual size, at about 10 or 20% in both of zone 1 and zone 3. In terms of issues that you're going to find, I think they're pretty obvious, really. The first one, if we go and sort of, I guess, forgetting the small C at the start, I'll go with A first. But in terms of airway, you've got problems with expanding hematoma causing airway distortion, which might cause airway obstruction, but also causes problems with you trying to insert an endotracheal tube if you're intubating the patient. And of course, also be aware of blood in the airway with the use of video laryngoscopy. I've been caught out a few times now, as of my teammates, with that camera. Seems to be a magnet for blood. So as soon as you put it in, you can't see anything. There's some decent data from the US military on Plan D or front of neck access in patients with neck injury. And these are typically Plan Ds that have been done by combat medics on the ground. So cat badge medics, not people, not doctors, not nurses, not paramedics. So relatively basic training. I guess the next thing is probably hemorrhage control, isn't it? So you obviously can't put a tourniquet around the neck. Well, I guess you could, but it's not ideal. And so you're left with diet pressure, gauze and haemostatics. That there was a product that I've not seen for a little while that was, I think, still recommended by the US military tactical combat casualty care guidelines, called the IT clamp, which essentially is this rather barbaric bit of kit that's a sprung piece of plastic with little teeth in it. And that has been, I think that's still recommended by TCCC for use in neck wounds. So that grabs the skin either side and bunches it together. I guess what other learners in the neck, it has around C collars. So cervical spine collars are generally not used as much as they, I think, have been previously. And a real concern with neck injuries is that you're going to cover up anything that might be changing in the neck. So you can imagine if you've got a C collar on a patient's neck and they've got an expanding hematoma, or you thought you controlled the hemorrhage and it started again, you're going to miss those structures. We also know that neurological injury or cervical spine neurological injury is very rare in penetrating neck injury. And if it is present, it's going to be obvious, or at least present on the patient's presentation. So less of an issue about trying to control the C-spine, more of an issue about trying to effectively manage airway and bleeding. I guess my experience of these sorts of cases is quite mixed, actually. It's quite dichotomized. So deployed, I've got a few cases of patients who were shot in zone 1. And that is a really challenging injury to manage. I think pre-hospital, your mainstay of management for that is to try and apply some direct pressure with hemostatic dressings and move as fast as possible to a surgical facility with a pre-alert, while giving blood products en route judiciously if you have those available. My other experience of this is in the UK, and they're typically zone 2 injuries from people who self-harmed. So I've had a couple recently that have gone through the platysma in zone 2 and damaged the external jugular vein, and both of those have been pretty easy to manage with a finger and one piece of gauze. Anything else about neck zones and injury?
No, I think that's pretty conclusive, actually. And my revelation was that actually zone 1 also includes the apex of the lung, and actually it can be quite easy to cause a pneumothorax or indeed tension pneumothorax by a zone 1 injury, because I consistently forgot how high the lungs can rise, and indeed the back of the chest. There was always, the front of the chest is always a clear visual indicator, but inspecting the back of the chest and the back of the neck actually was always one of my faux pas. Also, self-report. And I think one of the things I learned from seeing day in, day out penetrating injury was never rely on patients self-report, because they're hyperadrenalized. They feel like they've been punched when they're actually being stabbed. And actually the self-report is extremely poor as a objective indicator of injury. Moving on, Ed, and just looking at hypertensive management now. I think we're going to come on to critical hypovolemia as well, but just looking at hypotensive management, would you sort of still advocate for hypertensive resuscitation beyond that 2-hour time frame, or if not, what would you advocate for?
Yeah, that's a great question. And it's a question that has caused us some thought in military medicine in the last few years, with an idea that we're probably moving towards extended pre-hospital timelines in the future, potentially. So I think it's important probably just to review where all this started, really. And this all started in the city of Houston with the Bickle paper in 1994, which many of you will be familiar with. And this paper essentially randomized patients by day of the week who'd had penetrating torsal injury to receive a restrictive, i.e. no fluid resusc regime, or their standard therapy. And what they essentially demonstrated was that the patients who had a restrictive initial fluid strategy had a better survival. And this sort of changed the world of fluid resuscitation, albeit in a time when there was no pre-hospital blood. So these patients were getting lactated ringers, which is essentially Hartmann's. Now, since then, we've had some animal studies that demonstrate that if you have a severe hemorrhagic injury, then hypotensive resuscitation beyond about 60 minutes has a burden physiologically that might be unrecoverable. So there's this idea that that hypotensive resuscitation may be a strategy, not a target, for patients with penetrating injury up to about 60 minutes. Now, if you look back at the paper from Bickle in 94, their mean time to hospital from injury was about 30 minutes. And our UK median pre-hospital time is somewhere around 65 minutes, right? So we've got a difference in the timings. We also now frequently have access to blood products. We also don't see, outside of London, many penetrating torsal injuries, as tends to be blunt. We also see a whole mix of things with that blunt injury to torso, which commonly includes head, which really complicates matters around blood pressure targets. And we've also got older patients. So the mean patient age in the Bickle paper, I think, is 30 or 31 years old. So we're now in a situation where a lot of stuff's changed since 1994. We also have a desire to deliver precision medicine, don't we? So applying one broad brush to a whole group of different patients is probably not appropriate. And I say that in reference to older patients whose normal blood pressure may well be 150, 160 systolic. So it's a really complex area. And I think in most certainly in most UKED settings, planned hypertensive resusc is probably in consideration for very young patients with penetrating torsal injury who have an immediate plan to move to an operating theatre to have that controlled definitively. And I think it's a really difficult argument in all other patient groups. I think pre-hospital, we might have a window, particularly if you're going quickly to patients with a penetrating torsal injury who are younger. And I think it's appropriate in those patients as well. In terms of what we do in the military or more remote environments, it becomes a bit more complex, doesn't it? Particularly if we're in a situation where we have limited blood products and we're looking at 1, 2, 3, 4 hours. What do we do with those patients? What's the strategy? And clearly, there are some potential easier solutions. One of them is a walking donor panel. So that's, warm, fresh, whole blood. And then after that, you have novel interventions. So things like the AAJT, which isn't that well tested, which is the abdominal aortic junctional tourniquet, which in some respects is kind of a poor man's zone 3 REBOA, perhaps. And then, of course, we have REBOA. So I think I think the most important thing about all of this is it's really complex and it's in some ways individual to circumstances and the patient in front of you. So I think the most important thing to do is to have discussions in your clinical team before you're in a situation where you have to make these complex decisions about the patient in front of you. So I've not really answered the question, Ian, but it's a bit too complex, and it's definitely not a yes/no answer.
No, absolutely. And you're right, full of nuances, actually, according to the patient in front of you. Ed, could you speak to critical hypovolemia from a sort of definition perspective, and then sort of prospectively how to navigate that from your experience?
Yeah, thanks for that, Ian. So I think I might have put this phrase in your head, and I know in the UK we've got this sort of real sort of fixed idea about a systolic blood pressure less than 90. In other countries, it's a systolic blood pressure less than 100. And there's also some literature looking at shock index, which is heart rate divided by systolic blood pressure. And a normal value of that would be 0.5 to 0.7, and then more than about 1.0, we're thinking that it's a patient's compromised. So I don't think we've got a definition, or I certainly haven't got a definition of what critical hypovolemia means. And I think if I'm thinking about it now, I think there are probably patients who look pale, ask for a drink, start breathing more quickly, stop moving about as much, and become less conscious. So, those patients who fulfilled the hateful eight criteria of sweaty, pale, collapsed veins, lower falling end tidal CO2, hypotension, air hunger, a heart rate that's abnormal, and altered mental status. So I think it's quite dangerous to try and put a definition against what this is in terms of millimeters of mercury or a shock index. Something else I find useful, although we don't use it pre-hospital, is a base deficit. So a base deficit of greater than 6, I'm starting to get concerned that the patient in front of me is hypovolemic if they've had trauma, but that's not very helpful in the pre-hospital setting. So I think my definition would be along the lines of the hateful eight. And it's that patient who you look at, probably can't tell necessarily instantly, but after a very small amount of time, you can see that their trajectory is one of worsening signs of hypovolemia, not necessarily a cutoff of systolic blood pressure. In terms of navigating it, I think what's really useful about some of the more modern approaches to traumatic cardiac arrest is that the patients who are sicker in this group can have the same treatment, right? So they're likely to have the same things that we're trying to rapidly reverse in traumatic cardiac arrest. The benefit of this group is we can use a graded approach. So TCA protocols don't normally allow for individualization of treatment, but we could apply a TCA algorithm to these patients with some individualization. So an example would be not doing finger thoracostomies in a patient who you're pretty happy doesn't have a pneumothorax, for example.
So looking at sort of from an interventional perspective, Ed, we spoke about blunt abdominal injury or indeed pelvic injury and interventions such as zone 3 REBOA, which are complex interventions actually, and from my experience actually really difficult when there's adjusted or destructed pathology in front of your face, trying to find the appropriate anatomy. Could you speak to your thoughts on whether these interventions from a military perspective are better at point of injury or better in specialist centres?
Yeah, of course. So I should caveat this at the start by saying that all of my experience with intra-aortic balloon occlusion has all been in well-regulated large animal translational research. So my PhD is all about the strategies for the pre-hospital management of critical hypovolemia, which means I should probably be able to define critical hypovolemia better than I do. But so essentially, this has pretty much all come from the recognition that during the Iraq and Afghanistan conflict, the highest number of potential survival patients with some bleeding in the chest, abdomen, and pelvis, and there's a new term coined, non-compressible torso hemorrhage, or NCTH, and that comes off the back of the fact that extremity limb hemorrhage is easily controlled with the tourniquet, as we saw in the paper from Joseph Kelly in 2006. So we're then left with a situation where there's bleeding in the chest, abdomen, and pelvis, and a requirement to try and work out how we're going to manage that before the patient can get to a surgical facility. And what came out of that was a joint UK-US group of surgeons putting forward the idea that intra-aortic balloon occlusion would be a potential solution to this. So this was actually first seen in 1954, and there's a US military doctor who used the catheter in 2 patients in, I think, the Korean War, who had non-compressive torsal hemorrhage. And then it was forgotten about for a long time afterwards. And then since 2011, we've seen a bunch of large animal translational studies which seem to show that REBOA is, really useful, certainly in pigs who've got bleeding in the abdomen and pelvis. What we've seen since are a number of case series, predominantly, the first ones were out of the R. Cowley Adams Shock Trauma Center in Baltimore, which looked really promising. And what we've been left with now, though, I think, certainly from my perspective, is this elephant in the room of how do I know the patient in front of me needs REBOA? So it's not without risk. And I'm not completely sure that the iatrogenic complications and potential risks of intra-aortic balloon occlusion have been well described to date. And we've got this situation where we know that earlier intervention in hemorrhage is likely to lead to better outcomes, but REBOA is not risk-free. Some patients will survive without it. And then we've got later intervention, i.e. a patient's already in traumatic cardiac arrest, albeit maybe a low output state in trauma or lost. There's a better benefit risk ratio in that group of patients, i.e. they're more likely to not survive without REBOA. But then you've got the question of, will REBOA still be effective if I wait later? And there's really difficult sort of decision making around that. Now, there's lots of things we could possibly do to try and mitigate some of that risk benefit ratio or manipulate it in our favor to make a better decision earlier. And these are things around, obtaining early femoral access, because clearly obtaining femoral access in a hurry in someone who's even more shut down is more difficult. We're then also hoping that we get some data in the UK REBOA trial, which I guess might be released in between me saying this and the podcast going out, but was stopped early by the trial management group, and we're still awaiting what the issue with that was. And then we've got the evolution of REBOA devices, REBOA 2.0, which may reduce some of the risk associated with this device, which would change the risk-benefit ratio. So a bit of an unknown at the moment. Now, having said that, we talk about REBOA as one thing, and of course, you'll be aware that actually Zone 1 and Zone 3 REBOA are quite different things. So Zone 3 REBOA is a balloon sat at the aortic bifurcation, predominantly used to control pelvic hemorrhage and very proximal lower limb hemorrhage that can't be tourniqueted. Whereas Zone 1 is above the diaphragm, near the arch of the aorta. So clearly the ischemic burden for the rest of the body, the effects on cardiac afterload, probably causing subendocardial myocardial ischemia, and lots of other bits and bobs, spinal ischemia, renal ischemia, are quite different to Zone 3. And there's international consensus now, I think, that Zone 1 should be inflated for an absolute maximum of 30 minutes. And that really limits its use in pre-hospital care, because that means that you've got to be pretty close to a facility that's capable of handling that zone of REBOA. And there are problems, well, not problems, I guess there are. You need some people who know what they're doing when that balloon comes down. So there's likely to be some hypotension, hypokalemia, all sorts of other metabolites. Zone 3, however, we know can be up for considerably longer than that. And so, Zone 3, I think, in terms of your question, and I will get back there at some point soon, is probably more likely to be of use in my mind in a civilian setting, certainly. Now, in terms of military trauma, we're interested in it from some different reasons, and that is really around limited surgical capacity at somewhere that's really far forward, potentially with one operating team who are busy in a different patient's abdomen, and then another patient arrives who is about to exsanguinate from non-compressible torsal hemorrhage. So in that scenario, we're not using REBOA pre-hospital, albeit, well, I guess it is sort of pre-hospital. It's not in a big old hospital. It's in a tent probably. But we're using REBOA in that situation to literally hold that patient while the surgeons are able to move on to another patient. And that's quite different probably to using it in a patient pre-hospital to get them to a surgical facility. So I've probably given you an idea through all of that spiel that it's not a very simple technique. So I think, you're going to struggle to be delivering this intervention without a physician, I suspect, unless it gets a lot simpler in REBOA 3.0. So then you've got the issue of these patients are relatively few and far between. And our gap analysis from Tarn data was a bit overgenerous probably, but that suggested that even at the busiest trauma centres in the UK, you would see one eligible patient every 6 weeks. And so pre-hospital, you're going to be struggling potentially to find the right patient. Now, of course, we don't know who the right patient is, maybe, as we don't really understand who's going to most benefit from this, which I'm happy to talk about more if you're interested. So in terms of the answer to your question, is it worth the investment at point of injury? I'm not sure that it is, simply because the number of patients who may benefit from this and how long you can have the balloon inflated for before you need to get to a surgical facility are both really compromising factors at the moment for making this a solid recommendation.
So just shifting pace slightly, and I suppose going to the end of the spectrum really, and looking at TCA, so traumatic cardiac arrest. I've got a number of questions really for you on traumatic cardiac arrest. I guess the first one would be around sort of the survival bias that we've seen within empirical studies, and maybe if you could speak to some of the survival bias literature and or numbers before we kind of, I guess, get onto the nuances of algorithmic management. But yeah, just if you could speak to the survival bias numbers or reporting of numbers.
Yeah, I think TCA is my favourite topic, so I'm pleased you've asked about it. So what we saw in the 80s and 90s were a few reported studies that basically demonstrated an extremely low survival from traumatic cardiac arrest. So this led to an idea that actually it was a futile endeavour of more risk to the rescuers than it was of any benefit to any patients. And of course, that's a self-fulfilling prophecy. So if you don't resuscitate any patients who are in TCA, none of them survive, and therefore the survival is 0%. Now, what we've seen since 2005 is I guess almost a paradigm shift in reported survival, and reported is a really key word here. And what's really helpful is the European Resus Council guidelines in 2005 undertook a systematic review of sorts and synthesized the overall survival rate from TCA in those studies. And that was reported at 2.3%, so really quite low. And that's against the background, certainly in the UK or even in Wales, of a medical cardiac arrest survival discharge of around 7.98%. What's happened since then is there's been data from London's Ambulance and places in Europe, some data from the Trauma Audit Research Network here in England and Wales, and some data from the UK military, which appear to show this sort of upward trend. So if you look at the data that was published between 2005 and 2010 alone, we see that actually there's a 9.7% survival reported. So a massive increase from 2.3%. And then our military data, 2003 to 2014, demonstrated an 8.7% survival. So that actually exceeds what we'd expect from medical cardiac arrest. So that's all good news, isn't it? Having said that, and I said reported was a really important word, we haven't been including the same patients in these analyses. So in 2000, and I forget now, but maybe 5-ish, there was a definition for the first time of what traumatic cardiac arrest was. And that definition from the European Resus Council included patients who had agonal absence, spontaneous respiration, and absence of a central pulse. That's important because a lot of the studies in the 80s and the 90s only included patients with cardiac electrical asystole. So their heart's not beating at all and there's no electrical activity, which you would imagine from exsanguination certainly is pretty much an unsurvivable situation. So we've got the situation with this definition from the ERC that includes more patients. And what's important about that is the extra patients are less dead, which is a terrible phrase, but hopefully you understand what I mean. And by less dead, what I mean is the cohort that they added to that group were those who weren't in asystole. So they had ongoing electrical activity. You just couldn't feel a palpable central pulse. And that brings me to one theory, although not proven, about the military data, which was that a number of these patients were in the back of tactically moving helicopters with not much light. You're wearing gloves. And so trying to palpate a central pulse in those circumstances is a little bit absurd, particularly if you've got very low output. So there's a reasonable chance that there was a number of those patients included in the military analysis who, if you were in a resuscitation room with good light, no vibrations, nobody was firing at you, that you'd feel a central pulse, and they would never have been declared as TCA. Anyway, so we've got that issue. We've also got this thing, hopefully, that we now believe that traumatic cardiac arrest isn't futile. We know that traumatic cardiac arrest is different, both in etiology and hopefully treatments, to medical arrest. Hopefully been advances in trauma care, and all of that has led to a higher reported survival. The other thing that's really important to mention is survivor bias. So certainly for data in the UK, I think in most parts of the world, you need to survive to hospital to get a trauma number to be included in these data sets. So our denominator is only including patients who are transported. And anyone who's done more than a few days of pre-hospital care will know there's a decent proportion of patients who we sadly resuscitate or try to resuscitate unsuccessfully pre-hospital and don't convey. So the data that I published from TARN 2009 to 2015 demonstrates a 7.5% survival to hospital discharge, which grossly overestimates that, those numbers. More recently, we've gone into some pre-hospital data in the east of England, looking at just over 9,000 cardiac arrests, of which only 3% were traumatic, or 304. Got a lower median age than medical as you'd expect, and they're more male. And the survival of those patients was, I think, 3.8%. Although that still underestimates it a bit, because there's a proportion of patients who have traumatic injury who we never start a resuscitation attempt in. So my own personal estimate is that we're somewhere around 2 and a bit percent, maybe. So where we're at with it is that we've had, I think, probably some false reassurance in the last decades that things are substantially better. Although you should always be a bit cautious about that sort of paradigm shift in survival. And it's multifactorial, but interesting to dissect some of the reasons around how that's changed. I think the reality is there's a group of patients that we bundle together with lots of other patients. And there's a subset that are really survivable. And these are patients who have a low output state in trauma. So the heart is still beating, the blood is still going around, you just can't feel the pulse. And those patients typically require quite a small amount of filling initially to regain a pulse. And those are the ones that we're really interested in, together with the ones who've got airway obstruction and those who've got a chest injury leading to large or evolving pneumothorax. And that probably also tells us why we're interested in the things we're interested in when we talk about TCA management algorithms.
Yeah, absolutely. It brings me on quite nicely to TCA algorithmic approaches and just the nuances, really, and thinking about, I guess, what's killing the patient. But could you speak to the nuances, the famous paper by Prof. Lucky et al., the HOT algorithm, the hypovolemia, oxygenation, tension, pneumothorax. Could you maybe speak to when, not necessarily when that's not appropriate, but just the order in which you address the pathology?
Yeah, sure. So that I think the HOT algorithm was the first part of our change in mindset, practically, about how we approach these patients. Really useful to have an immediate action drill, in the same way that we do for medical cardiac arrest, which is start chest compressions, right? And then that buys you time. It's a holding measure. And what we really needed in traumatic cardiac arrest was initially that recognition that it's different to medical arrest, but then also what do we do? And there are some problems with the immediate action drill, which I'll come on to in a minute. I find it really hard to remember what HOT stands for, so I'm really glad that you've just gone through it, although I've already forgotten it. So, and I've stolen this from my academic boss, Surgeon Captain Jason Smith, so thanks, sir. But we think about oxygenate, decompress, and fill. And I just find that easier in terms of I don't have to try and remember what that stands for, and I know what the immediate priorities are. So oxygenate, decompress, and fill is all about what do we think people are not just dying of in trauma, but what do we think they're dying of and we can manage that means they're going to survive. So that's about oxygenate, which is an iGel or an ET tube. More commonly in my practice now, actually an iGel, because it's super quick. And then oxygenate the patient or ventilate them at least. Decompress is about releasing air from the pleural space. So that is either a needle decompression, or if you have the skill set and equipment, then that's finger thoracostomy. And then fill, which is one of the most important things and probably runs to the top of that in our military cohort in most circumstances, is all about getting volume loading. And we get our knickers in a twist regularly about what fluid we're going to give these patients. And clearly, warm, fresh, whole blood is almost certainly the answer. It's almost certainly never available. And there's some good work from DSTL Porton Down in recent years demonstrating that crystalloid's better than nothing, quite a lot better than nothing. So if you're working in a service or in a situation where you haven't got blood products, these patients need volume. So preferably warmed, but crystalloid is definitely better than nothing. So I've kind of forgotten your question a bit, Ian, but it's something about the order. Now, I'm not really sure there is an order in terms of the first bit, and I talk about different steps of approach, and that's step one for me is oxygenate, decompress, and fill. The only caveat to that is if you've got penetrating injury that you think may be causing a pericardial tamponade, right? And that goes, there's like a snakes and ladder on my diagram for that. And if that's the case, then step three is think about resuscitative thoracotomy, but I've got a little snaky that goes all the way from there up to the top for that, because we know that in the best circumstances, not pre-hospital, but in an operating theatre, there's up to 20% survival in those patients. And then step two includes stuff like apply or check if they've already been applied, combat application tourniquets, shake the long bones out to length, address max hemorrhage, that sort of thing. Apply dressings to wounds in keeping with good damage control resuscitation principles. And then step three is about consideration of chest compressions, resuscitative hysterotomy and resuscitative thoracotomy. But that's just the world according to Ed Barnard.
So Ed, what's your perspective on chest compressions within trauma?
So I think this is a question I get asked the most around the management of traumatic cardiac arrest. And I can think of some really good situations I've been in with hemorrhagic trauma where I've had to go, on my graded assertiveness scale, I've had to go straight to stop. But on multiple occasions with a patient who people won't stop giving chest compressions to, and it's really getting in the way of a bit of volume loading. And they're typically patients. I think the last one was a patient who'd been stabbed multiple times in his buttocks and groin and was in a low output state in trauma, and he just needed a little bit of filling. Now, if we look at the literature from this, the paper I always think about is the one from Maluna et al. In 1989, and he did experiments on large baboons, and he bled out these baboons to a low output state in trauma, essentially. It's like a blood pressure of maybe, 40 or 50 systolic. He then started external chest compressions on these animals. And what we saw with that was that the systolic blood pressure went up, which is, good. Everyone's happy about that, right? The monitors has better numbers on it. But importantly, the diastolic blood pressure went down. And what's important with that is the myocardium gets its blood supply during diastole. So what you're doing in this situation of hypovolemia and chest compressions is starving an already struggling myocardium of oxygenated blood and substrate. What he then did was stop chest compressions and then give the animals back the blood that he'd shed from them. Unsurprisingly, because it was a controlled hemorrhage, they got a return of spontaneous circulation. And this has been repeated in, I think, 2018-19 by the team at DSTL Porton Down. And they essentially randomized randomized pigs into 5 different treatment groups after they'd had 60 minutes of hypovolemia. And essentially, the pigs that did the best were those who received blood, and those that did the worst got chest compressions from a Lucas device. So, in the setting of hemorrhage, we know that the chest compressions have got lower survival than filling alone. They definitely slow filling down. So, if you've got a Belmont device, for example, attached to a subclavian line, and you're trying to fill and give chest compressions, that increase in pressure in the chest just stops the Belmont running. It makes airway and ventilations more difficult, gets in the way of chest decompression. It likely worsens thoracic injury, so you're pushing broken ribs around. And of course, it increases the risk to the rescuer, and it makes us all very tired and stressed. So that's quite an easy answer. And I think this is where this de-emphasis of chest compressions has come from. And the military is probably responsible for a good part of that, because it would be atypical for us to suggest chest compressions in somebody who is exsanguinated. Having said that, we don't treat young fit soldiers in civilian pre-hospital practice. And when looking through the data from the east of England on cardiac arrest that I mentioned earlier, we discovered something really interesting, I think, which was that the presenting rhythm, i.e. the first cardiac rhythm recorded by the ambulance service in these patients in traumatic cardiac arrest, had a difference in age. And by that, what I mean is people who had a shockable rhythm, VF or VT, were significantly older than patients who presented with a PEA, or as I call it, a lost or output state in trauma. And that leads us to believe that there's a group of patients who are older, who have a primary medical event leading to a cardiac arrest and then have trauma. So the classic is, driving a car slowly into the Armco barrier on the motorway, but no massive trauma, but the patient's in cardiac arrest, or a patient who has a cardiac event like a stroke and then falls over and has an injury. So a typical one that I see quite a lot, older patients, we arrive at TCA and they've got a bloody nose from falling over, but the initial event was actually medical. Now, in these patients, we know that chest compressions and early access to a defib is absolutely life-saving. And so we've got this sort of difficult situation where, although we want a single immediate action drill for patients with traumatic cardiac arrest, I'm not sure it's entirely applicable, because there are patients who absolutely need chest compressions early on as part of their sort of ALS algorithm. And then there's a group of patients, are those who are bleeding to death or have bled to death, who absolutely don't benefit from chest compressions. So that's a sort of difficult area to sort out.
So, Ed, just coming to land on the conversation and just looking at your sort of reflective practice, really, and I suppose it's a question around sort of is there any approaches or mindsets that you have now through the evolution of your experience that you didn't maybe have 5 years ago?
Yeah, sure. I mentioned one of them already, I think, which is around the small amounts of non-blood product in certain settings. And that really comes from two things, really. That, first of all, comes from the work at DSL Porton Down, demonstrating that, crystalloid's better than nothing at all, albeit we're sort of very wed to the idea that it's only balanced blood product resuscitation. And clearly we can't, give patients 7 litres of crystalloid because they're going to do very badly. But I would now, in some settings, give patients who've had trauma, who are not obviously exsanguinating, a 250 ml warm crystalloid bolus in the ED just to see how they react to it. I think the second one is around chest injuries, and the committed trial has recently started recruiting. And this is all about how we manage small to moderate pneumothorax. And we know that there are risks, iatrogenic risks, from inserting a chest drain or finger thoracostomy. So is there a group of patients in whom we don't actually need to insert a chest drain or do a finger thoracostomy at all? And certainly my practice has changed over the last 5 years in respect to this, where I used to have a very dogmatic approach of all these patients who are anyway unwell are probably going to get their chest decompressed. So I think the use of ultrasound has helped with that, but I think we're going to get hopefully a nice answer out of the committed trial, which essentially is randomizing patients for chest drain or not in small, moderate pneumothorax following trauma. I think my other one is really about speed. So I sometimes talk about the HEMS benefits, or the benefits of HEMS, and I can hear a bunch of registrars in the east of England sighing heavily as they hear this. And I think about time intervention, decision-making, education and support to EMS, or TIDES. And I've got an increasing recognition, I think, that although we need to move quickly pre-hospital, I think there's sometimes a bit too much emphasis on that. And clearly patients that we've spoken about today who are bleeding, they need to move quickly to somewhere that can gain surgical control. But there's a group of patients we go to with, for example, traumatic brain injury without a lot of bleeding elsewhere, who need a really careful approach aimed at high quality neuroprotection, including a pre-hospital anaesthetic. We've done some work over the last few years, which we're hopefully about to publish, looking at the differential determinants of post-FEAR hypotension. And that's has some really interesting bits to it. And it really highlights to me that, there are some patients who don't need blind speed pre-hospital. They need a sort of graduated or more sensible approach to that, really. So I think, in summary, the speed of pre-hospital interventions needs to be more nuanced to the patient in front of you. And my last one's really about civility, which I've certainly had in the last few years in my emergency medicine practice in and out of hospital. I've got an increased appreciation of how individuals' behaviour or my behaviour can detrimentally influence the people around me, and not just for that job, but for the rest of their day or even longer than that. So I'd really encourage anyone listening, if they haven't seen it before, to take a look at the Civility Saves Lives programme available online.
Yeah, listen, that's fantastic. And those recollections are absolutely gold. What I will do is I will signpost in the show notes to both the articles that you mentioned within the interview and also the Civility Saves Lives. I'll signpost that link so that people can look that up. It just leaves me to say thank you, Ed, for the last hour, because I really appreciated both your reflections and your perspectives.
It's been a pleasure. Thanks very much, Ian.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.